Welcome to our new program called Dialogues and Directions, brought to you by the PCOS Society of India. This series of 5 podcasts of approximately 30 minutes each is dedicated to the latest International Guidelines on PCOS 2023, which were published in August 2023. I'm Dr. Duru Shah, the President of the PCOS Society of India, who has had the pleasure of being a collaborating partner with 37 other organizations in this huge project led by Monash University and CRE PCOS. We are delighted to have with us one of the most eminent global leaders in PCOS, Dr. Michael Costello, who has chaired the infertility section in these guidelines. I would like to introduce Dr. Michael Costello, who is a gynecologist and specialist in reproductive endocrinology and infertility at CREI. A CREI qualification is Australia's highest awarded qualification in the field of infertility, and it is acknowledged by the Royal Australian and New Zealand College of OBGYN. Michael is also a recognized Australian and international expert in polycystic ovarian syndrome, unexplained infertility, and IVF. Michael has obtained further academic qualifications, including a master's in reproductive medicine by the University of Sydney in 2002 and a Doctor of Medical Science by the University of New South Wales in 2015, with the latter degree establishing Michael as an international authority in infertility disorders. So you can see the authority of the person who's going to be speaking to all of us. He's extremely passionate about education and a senior lecturer in OBGYN at the UNSW and a clinical academic with the Department of Reproductive Medicine at the Royal Hospital for Women. Michael lectures regularly at local, national, and international scientific conferences and has written over 100 medical publications, including scientific journal papers, books, chapters, and various other publications. These academic commitments allow Michael to be at the leading edge of latest research, which he applies to his clinical practice. Dr. Michael is nationally and internationally recognized, and he's the author of various guidelines which he has produced. And we see them over here, which are listed as awards and honors and achievements, which are something which we're all proud to know that he has been such a great achiever. He's the author of ESHRE Guidelines on Infertility, published in 2023, and also the author of a consensus review publication on IVF, published in 2023. Being in clinical practice, I'm sure Michael's patients will appreciate Michael's thoughts and thorough professional approach. He believes that if something is worth doing, then it's worth doing properly. This belief, along with contributing to the latest evidence-based research and guidelines on infertility treatment, leads him to provide patients with the best possible clinical care. So I'd now like to invite Dr. Michael to give his presentation for approximately 15 minutes, which will be based on the guidelines of this 2023 publication, and we will discuss infertility through these guidelines. So, Dr. Michael, may I request you to start your presentation?
So thank you very much for that very kind introduction. It's an honour and a privilege for me to be invited to speak to this webinar today. And the title of my talk is the 2023 International Guidelines on PCOS, What's New in the Assessment and Treatment of Infertility. Okay, all right. After that little hiccup. So today, my presentation outline will be, I'm going to be comparing essentially the current most recent 2023 guidelines with that of the 2018 guidelines, which were the first ever evidence-based guidelines or international evidence-based guidelines on PCOS. In terms of the fertility management, we'll look at some of the methodology changes, some recommendation changes, and the new algorithm. We'll finish off with that. It's important to know how to interpret the recommendations. And you'll see from my presentation, there's three main categories of recommendations. There's evidence-based recommendations, and that's where the evidence was sufficient in PCOS to inform the recommendation. There are CR or consensus recommendations, and that's where there was an absence of adequate evidence in PCOS. And the recommendation was informed by evidence from the general population. And there are PP or practice points where the evidence was not sought, but these practice points were made where important issues arose from discussions of the evidence-based recommendations or the consensus recommendations. And there's also categories of the quality of evidence being from high, moderate, low, very low, and there's different strengths and directions of recommendations, with recommendations can be conditional or weak or strong for either the option or the or against the option. Probably the main difference, or a big difference, this guidelines was that the fertility guideline section was guideline development group 5. We solely looked at randomized controlled trials for evidence, and we applied a research integrity check to the studies before then analyzing the studies. And this is a new process and what we believe we're probably the first guidelines who have ever done this process. So normally with grade steps, we have to ask the clinical question in terms of a PICO, in terms of the patient, intervention, the comparison and outcome. We have to search for and collect the evidence. And in these guidelines, when we did our systematic review of the RCTs that we identified, first of all, we did a data integrity check before we then summarized the evidence and performed their analyses. And the research integrity and guideline development framework, or RIGID that we named it, involved searching for the studies and getting the studies, identifying the studies. And then we had a separate integrity committee, which then labeled the studies as being low, moderate, or high risk. And moderate and high risk studies, we contacted the authors, and these studies were included if the authors responded an acceptable explanation to our concerns regarding the studies. But if the authors didn't reply, or they needed more time to explain our concerns that we had, then the studies were put in a waiting classification. And you can see here from the results of the literature search that we had for the whole fertility section. There were 102 RCTs that met the inclusion criteria. And of those, we included 57. 45 were excluded. That's because 2 had been retracted. 34 RCTs, there was no response from authors. And 9 RCTs, we had a response from the authors, but they're in a waiting classification, with the authors intending to provide adequate explanation at a later date. So how I've done it for today's presentation is anything in the yellow highlighted is new in the 2023 guidelines compared to the 2018. So the assessment and treatment of infertility for the general principles, there were 4 new practice points, and these were that all fertility treatment in PCOS should be guided by the fertility treatment algorithm, and we will look at that algorithm at the end of this presentation. Those with PCOS should be reassured that pregnancy can often be successfully achieved either naturally or with assistance. Prenatal vitamin supplementation should be commenced with ovulation induction therapy aligned with routine preconception care. And there should be ongoing monitoring of patients for adverse effects and infants for congenital anomalies in all studies conducted with ovulation induction agents, and these should be reported in any published papers. Looking at the preconception risk factors, there was a new evidence-based recommendation where women with PCOS should be counselled on the adverse impact of excess weight on clinical pregnancy, miscarriage, and live birth rates following infertility treatment. Now we can see this was with the 4 diamonds here, that's a strong recommendation. And strong recommendations, we usually use the word should, whereas with weak recommendations, we use the word could. And this was actually based on very low quality evidence. There's a clinical recommendation about routine preconception care, where we also included nutritional status and being a higher folate supplementation for those with a BMI greater than 30. And 3 other new practice points about a reproductive life plan and appropriate education on optimizing reproductive health is recommended in adolescents and women with PCOS, including healthy lifestyle, prevention of excess weight gain, and optimizing preconception risk factors. Another practice point being healthcare professionals are encouraged to seek permission and, if given, to assess weight and BMI and initiate a dialogue on the importance of weight and lifestyle on women's health before pregnancy. And the other practice point is chronic conditions such as diabetes, high blood pressure, anxiety, depression, and other mental health conditions should be optimally managed, and women should be counselled regarding the risk of adverse pregnancy outcomes. So they were new to these guidelines. When we look at letrozole, this time letrozole was still recommended as the first line pharmacological treatment for ovulation induction. Now, all with these treatments, you'll see, particularly for ovulation induction, it's in infertile and ovulatory women with PCOS with no other infertility factors, okay? Because that's what our literature search look for, that's setting, okay? In 2018, the recommendation was based on low quality evidence. This time the evidence was high quality evidence. And we added a practice point that there is no evidence for increased teratogenicity compared to other ovulation induction agents for letrozole. Looking at clomiphene citrate and metformin section. So when we're looking at metformin versus placebo, metformin could be used as an ovulation induction agent, but it's important to inform women that there are more effective ovulation induction agents. That remained unchanged to the 2018 guidelines, but with these guidelines, the evidence was low quality compared to moderate quality in 2018. And there were 3 additional practice points made where women should be counselled as to the potential mild gastrointestinal side effects with metformin. Healthcare and resource burden, including monitoring, travel, and costs, are lower with metformin. And consideration of age and screening for other fertility factors needs to be discussed before prescribing metformin. When we look at clomiphene citrate versus metformin, the recommendation is for clomiphene citrate could be used in preference to metformin. In 2018, that was restricted to women with a BMI of greater than 30. This time it was for all women with PCOS. And there was an additional practice point where the risk of multiple pregnancies increased with clomiphene citrate either alone or when combined with metformin. And therefore, the cycles may require ultrasound monitoring. When we look at clomiphene citrate combined with metformin versus either clomiphene citrate alone or metformin alone, in 2018, the combined therapy could be used in preference to clomid alone in all women. In 2018, it was restricted to women with clomiphene citrate resistance. And for clomiphene citrate combined with metformin versus metformin alone, 2023, it's for all women with PCOS, whereas 2018, it was the evidence was only in women who had a BMI greater than 30. And we added in a practice point that monitoring of combined cycles will need to be equivalent to clomiphene citrate alone. Looking at gonadotrophins, we made a new evidence-based recommendation where gonadotrophins alone could be used over gonadotrophins combined with clomiphene citrate in women with PCOS who are anovulatory, infertile, and with clomiphene citrate resistance or failure, and no other infertility factors. So that's as a second line treatment option. Just use gonadotrophins alone, don't combine with clomid. And the evidence-based recommendation for gonadotrophins, you can see that the evidence changed, or the quality of evidence and the strength of recommendations changed between 2023, 2018, particularly in the with the evidence-based recommendations here, is that either gonadotrophins or laparoscopic ovarian surgery could be used in women with PCOS who are anovulatory and infertile with clomiphene citrate and no other, or resistance and no other infertility factors, following counselling on a higher live birth rate and higher multiple pregnancy rate with gonadotrophins. Back in 2018, there was no evidence of a difference between the live birth rate between gonadotrophins and laparoscopic ovarian surgery. This time around, we found a higher live birth rate with the gonadotrophins. We also had a practice point about to avoid multiple pregnancy cancelling cycles in the 2018 guidelines. We just said 2 mature follicles then. This time we were a bit more specific and said if there's more than 2 follicles greater than 14 millimeters diameter to cancel the cycles to avoid multiple pregnancy. And we added in 2 practice points there, being live birth rate, clinical pregnancy rate per patient, and ovulation rate per cycle are higher with gonadotrophins than with clomiphene citrate. That's actually specific to therapy naive women undergoing ovulation induction. And the other practice point was that cycle monitoring and drug costs coupled with multiple injections will influence the choice in gonadotrophin use. When we look at IVF and in vitro maturation, first of all, looking at the protocol in IVF, new practice point stating that the GnRH antagonist protocol cannot be recommended over the agonist long protocol for women with PCOS undergoing IVF ICSI to improve clinical pregnancy or live birth rates, okay? But we also added the practice point that the antagonist protocol for women with PCOS undergoing IVF is actually recommended because it's not because it improves clinical pregnancy or live birth rates compared to long protocol, it's because it enables the use of the agonist trigger with freezing of all embryos generated if required, without compromising the cumulative live birth rates to reduce the risk of significant ovarian hyperstimulation syndrome. And when we looked at the type of trigger in 2018, this was a practice point. This is now a consensus recommendation in these guidelines, being triggering final oocyte maturation with a GnRH agonist and freezing all suitable embryos is recommended in an IVF ICSI cycle with a GnRH antagonist protocol where a fresh embryo transfer is not intended or where there is an increased risk of ovarian hyperstimulation syndrome. When we look at adjunct metformin, in 2018, we also said that adjunct metformin therapy could be used in the long agonist protocol to reduce developing ovarian hyperstimulation syndrome. And the evidence this time was also that it reduced miscarriage as well in the long protocol. With in vitro maturation, these guidelines were able to make an evidence-based recommendation. In 2018, it was a consensus recommendation, so population women not with PCOS. This time it was with women with PCOS, and that was that the use of IVM and ICSI could be considered in women with PCOS and as an alternative to stimulated IVF ICSI cycles, where an embryo is frozen and replaced in a subsequent embryo transfer cycle, acknowledging there is no risk of ovarian hyperstimulation syndrome but a lower cumulative live birth rate with IVM. And as I said, in 2018, there was no evidence specifically in PCOS, whereas there was in 2023. And there were 2 additional practice points where IVM could be offered as an option in women with prior severe ovarian hyperstimulation syndrome, where the risk of severe ovarian hyperstimulation syndrome is deemed unacceptably high, provided that expertise in vitro maturation techniques exist. So as I said, the yellow parts are the new wording, or the new parts to the 2023. And the other practice point was evidence suggests that IVM ICSI is less effective than standard IVF ICSI in terms of clinical pregnancy per patient and live birth rate per patient. In these guidelines, we didn't have a section on inositol in terms of fertility, in terms of reproductive outcomes in 2018. These guidelines, we did look at inositol for reproductive outcomes. So we've got a new section on inositol, and was the evidence-based recommendation that inositol in any form alone or in combination with other therapies should be considered experimental therapy in women with PCOS with infertility, with benefits and risks currently too uncertain to recommend the use of these agents as fertility therapies. Practice point is there's limited evidence with uncertain results on the effect of inositol on ovulation, clinical pregnancy, and live birth rates. Side effects and safety are not known for inositol. Women need to be aware that these agents can have limited regulation with variable dose and quality, consistency in combination with other agents, and women's personal goals and preferences should be considered when discussing complementary therapies. And we also had no section on anti-obesity pharmacological agents in 2018 for fertility outcomes. So these guidelines, we looked at this as well, and in fact there were no RCTs in this area. So that's why we made a consensus recommendation where we recommend using anti-obesity agents in PCOS for reproductive outcomes only in research settings to establish the efficacy and safety. So this is the new algorithm, which is completely new to the 2018 on how to manage infertility in PCOS. The central blue pathway is considered best practice. And so first of all, make a diagnosis using the international guideline criteria, full baseline investigations. These are listed at the bottom of the algorithm. We're going to optimize preconception health and lifestyle before ovulation induction. And letrozole is the first line agent. Or you could consider, with full explanation of risk, benefits, efficacy, and cost, clomiphene citrate combined with metformin, which is preferred to clomiphene citrate alone. Or you could consider clomiphene citrate alone. You could consider metformin. Metformin's low cost, low efficacy, no monitoring. Or you can even consider gonadotrophins, which is high cost, multiple pregnancy, higher efficacy, and monitoring. And if the first line medical treatment, if ovulation is detected, then you continue that with repeated cycles. And it's a shared decision-making between the doctor and the patient, considering the patient's age and resources before then moving on to IVF as to how many cycles you want to do. But if ovulation is not detected with the first line, then we move on to gonadotrophins is preferred as second line, or you can consider laparoscopic ovarian surgery also. And again, if ovulation is detected with the second line therapy, in that case, repeated cycles, and again, shared decision-making, considering age and resources, then on to IVF. If there's no ovulation detected with the second line, it's time to move on to IVF. And this is a photo of the Guideline Development Group 5. So we were the fertility guideline group. That's us spending 2 intensive days in LA in October last year, following the ASRM in LA last year, to just sift through all the evidence and doing the draft recommendations. So it's obviously not a single person that's that is involved in doing this. It's a lot of people, and so here, as I said, the Guideline Development Group 5, and there's obviously we were helped with an evidence team, and Helena Teed being the project director. And thank you very much.
Thank you so much, Dr. Michael. That was a very, very interesting session related to the change of the guidelines 5 years after the first ones, which were developed in 2018. And I think the areas you put across, there are a few questions which I have in mind to ask you. That the first being that why do we now say that letrozole is the first line therapy compared to clomiphene when we treat our patients with of PCOS for infertility management? What is the basis behind that?
And so the basis for that is basically the evidence supporting letrozole in terms of the outcome live birth rate came from 3 sources. Okay, came from our guidelines, our meta-analysis of our RCTs that we identified. And I'll also just mention that these 3 sources that I'm about to talk about all underwent data integrity checks. Okay, so the first one was our guidelines, our meta-analysis, and it showed that letrozole was, and this is in terms of live birth rate, and this will be for all of the sources I'm talking about, that letrozole is superior to clomiphene citrate, FSH is superior to clomiphene citrate in therapy-naive women. Clomiphene citrate is superior to metformin alone, and metformin alone is superior to placebo, and the combination of clomiphene citrate with metformin is superior to either clomid or metformin alone. There was also the Cochrane updated systematic review on aromatase inhibitors, letrozole, published in 2022. It also showed that letrozole was superior to clomiphene citrate either alone or with adjunct therapies such as metformin and FSH. And there is the Wang 2022 BMJ paper that we published back in 2017, which was the first network meta-analysis where you can actually compare all the individual ovulation induction agents against each other. And we updated that publication last year by doing a data integrity research and excluding the RCTs that were in question. And our updated analysis showed when you rank all the therapies, ovulation induction in therapies against each other, that in terms of the outcome live birth rate, that letrozole is number 1, followed by FSH, followed by clomiphene citrate combined with metformin, followed by clomiphene citrate alone, followed by metformin alone, and followed by placebo or no treatment. So that's where the evidence came to support letrozole as being the first-line ovulation induction agent in PCOS.
So there's so much evidence on letrozole. As a matter of fact, in India, we use a lot of letrozole, and we use it as a first-line therapy for our patients, especially for the PCOS ones, because we find that the estradiol levels don't go as high as they go with clomiphene or with gonadotrophins when we are inducing ovulation. And the concerns are that in some countries it is still off-label use. So how do you explain that? Why is it off-label?
Well, it's off-label use probably it's off-label use in Australia as well, and probably in most countries, because letrozole is actually indicated, or it's on-label use, so to speak, is for hormone receptor positive breast cancer in postmenopausal women. Okay, and it's actually, when you open up the product insert, it will say contraindicated in women who are premenopausal. Okay, and that all came about because back in 2005 there was a oral abstract presentation that had a lot of methodological flaws, but it was presented at ASRM in 2005, and it suggested that there was an increased risk of bone and cardiac defects with letrozole. 1 month later, Novartis, who was manufacturing letrozole, sent a letter to all the physicians in the world saying that, you know, letrozole or Femara is contraindicated in women, in premenopausal women. Okay. Now that oral presentation, which was published in an abstract format in the conference handbook, was never able to be published in a peer-reviewed scientific journal because of various methodological flaws and limitations, I guess, of the study. Since then, there have now been more than 10, 12, 14 or so studies, both observational and RCTs, that have looked at the risk of congenital abnormalities in children with letrozole use and ovulation induction, and these studies all are now reassuringly showing that there is no increased teratogenicity or increased risk of abnormalities. But despite that, people who, you know, the pharmaceutical companies making letrozole haven't changed their label use. So
yeah, I think every time they need to submit any product for use, they have to give an indication for which they are using it. And I think the whole process of getting it reset by the for approvals probably takes a long time. And unless there is enough evidence to show that it's not causing any problem, I think that regulation may not change. But are you expecting it to change? Any idea on this?
No, I don't really have any idea, but I expect, as you say, it does. It takes time and effort and money to get these things changed, and I suspect they already realise it's being, you know, there's guidelines like our guidelines coming out saying use it first line, so and they know it's being used first line, so probably
it might help, I'm sure. The other question I had is that we talk about using metformin, which we add to either the letrozole or to the clomiphene to give us better results. I mean, and do you like to, I mean, would the guidelines say, it says that we give it to all PCOS women when they are starting ovulation induction. Does the dose matter as to what dose we give it to the patients? Is it
we didn't look at dose, but there are other systematic reviews and things where we that have looked at whether the dose matters, and it doesn't seem to matter, all right, in terms of the dose of letrozole. But we recommend starting at the lowest dose, obviously, which is 2.5 for the 5 days, days 3 to 7. If the woman is anovulatory, then move to 5 milligrams. If the woman's still anovulatory, move to 7.5. And that's the maximum dose. And if the woman's still anovulatory, then need to move on to something else. So,
okay, so that's for the letrozole. What about the metformin? You're recommending it for all PCO patients to be given for ovulation induction, adding on the adjuvant of metformin.
You mean adding metformin to letrozole? All right. So when you look, that's where we need further research, because that's where you would suspect that there may be an improvement, but we don't know, and that needs to be studied. But there is actually no RCTs, with comparing letrozole versus letrozole plus metformin, there were 2 RCTs that we identified. They were small RCTs. They showed, each of them showed no evidence of a difference, all right? And when you did a meta-analysis of those 2 RCTs, it was still way underpowered. No evidence of a difference between letrozole alone versus letrozole combined with metformin. But the 95 confidence intervals were very large, all right? So, and because of that, we're uncertain, all right? It's inconclusive. We just don't know whether it helps or not, all right? We can't say it's equivalent because of the large 95% intervals, 95% confidence intervals. So what we need is more RCTs to try and get more precise results so that we are then confident whether it works or not. So we need more trials in that setting.
Yeah. But women who are going through IVF, we normally would use metformin to prevent ovarian hyperstimulation and PCOS women especially. So do you tend to recommend that? I think the guidelines do say that you use metformin.
The evidence for metformin is only in women with the long agonist protocol, where it
Yes.
reduces OHSS
Yes.
and it actually reduces miscarriage. When you look at women with the antagonist cycle, it didn't reduce OHSS. And I've published other systematic reviews, Cochrane reviews on this same topic as well. And this is without the data integrity check. And this was, I think, 2 years ago or so. And it's actually the live birth rate, clinical pregnancy rate was actually lower with metformin.
With metformin.
For some reason. But in our data, there was no evidence of a difference in the clinical pregnancy live birth rate in using metformin in the antagonist cycle. So really, if you're going to use metformin, it's really just for women in the long protocol. But as you know, as you heard, we are recommending that women with PCOS should actually be on the antagonist protocol.
Yes, absolutely.
And that's so you can use the agonist trigger freeze all, which is far more effective, I guess, than metformin would be anyway. So
yeah, I think most of the cycles now with PCOS are going into antagonist cycle with a agonist trigger and freeze all following that. But there are women with PCOS who are insulin resistant, and if they have been kept on metformin even prior to their stimulation, I suppose we continue with the metformin during ovulation, during the COS cycle. I think that would be something which would normally be done.
Sorry, you said there are women who are what?
Insulin resistant. The ones who have.
So that hasn't been. We don't know. So the studies that have been done have not been selective in the women undergoing IVF who are specifically insulin resistant.
Yes.
Although most women with PCOS are insulin resistant, but to some degree anyway. But it's hard to know. You may be right.
Okay, the last question for you, Dr. Michael, is we are following these general principles of managing fertility treatment based on your algorithm, especially. When we do the folic acid, you said with higher BMI women, you would give a higher folic acid dose. So what would you recommend in women? Normally, we would give 1 milligram. In women who are obese, we would probably raise the dose of folic acid much more than that. Because that's
we didn't look at that. We didn't look at that specifically. So that's why that was a practice point, meaning it just came up while we were talking about things. And it was that's like expert opinion, okay? The practice points.
Yeah.
And so personally, I mean, from my understanding with folic acid is that to reduce the risk of spina bifida is you need to use at least 400 micrograms a day.
Right. Yeah.
And higher dose, I've always used 5 milligrams.
Yeah. Yes. Right.
In women who are at higher risk of having spina bifida, such as BMI greater than 30, being on an anti-epileptic, having type 2 diabetes and so forth. So they're all risk factors. So they're the ones who I put on the high dose at 5 milligrams daily.
So yeah, I think so. With all these preconceptional adjuvants which we give to our patients, is there anything specific you would like to add for PCO patients besides the normal what we give it to all our other patients? Like we normally
probably. I think the only thing from the guidelines that is specifically extra for the women with PCOS, because everyone generally we need to talk about lifestyle, cigarettes, alcohol, drugs, diet, exercise, weight, blood pressure. For everyone, I guess, folate for everyone, antenatal screen, rubella, all that, that's for everyone as well. I think
Yes.
the specific one is to test the glycemic status in women with PCOS. And it's been recommended an oral glucose tolerance test, but if that can't be done, HbA1c.
Yes.
And it's been recommended to do that in anyone who's thinking about conceiving or having fertility treatment, all right? And do it before pregnancy. If it's not done before pregnancy, then you should offer the testing of the glycemic status, oral glucose tolerance test, or the HbA1c at the first antenatal visit.
Yes.
And then it's also recommended, because women, as you know, with PCOS have an increased risk of gestational diabetes, they should also be tested with a full oral glucose tolerance test between 24 to 28 weeks gestation. So I think it's really just the glycemic status testing is the one that's really specific to women with PCOS.
Absolutely. I think it can definitely, I think, reduce the chances of large birth weight babies, gestational diabetes, etc. We need to track these women right from the preconception area. But many women come to us only after they are pregnant. So we need to guide PCOS women. Actually, what we tell them is, whenever you're not using contraception, just start taking the folic acid. It's not going to harm you. You never know when you'll be pregnant. So it's just a thing to do that. So I think, thank you very much, Dr. Michael. It's been a pleasure talking to you. And we will have many more such webinars with the podcast, with the other members of our team, with all the other group members, and take the guidelines, the latest guidelines, to our global community. That's exactly what we wish to do. And thank you very much for being with us. I thank Torrent Pharma also for their unrestricted educational grant and supporting this entire series, and web stream for their recording. Thank you very much.
Thank you very much for inviting me. And in fact, I think about 6 weeks ago, I had the pleasure of coming and speaking in Chennai. So I very much enjoyed my time in Chennai and India. So thank you very much.
Thank you. Thank you so much.
All right. Thank you.
Bye-bye.